on imaging of adnexal masses. And so it's going to be, a review of what we need to do. And I want to insist what our duty really is we need to give a specific diagnosis when possible, because this really helps guide management. And what we need to consider, in addition to, of course, the sonographic characteristics, is the age and menopausal status of the woman, a potential risk factor for ovarian cancer, such as, for instance, familial history of ovarian cancer or Lynch syndrome, if there are any clinical symptoms, and also lab abnormalities such as CA125. So we really need to have a global picture of the patient. And so when we talk about evaluation of adnexal mass, ultrasound is widely accepted as a first imaging modality. It will involve not just transabdominal, of course, endovaginal and color and power Doppler. And, several studies have shown that expert sonographic interpretation is highly accurate in differentiating benign or leave-alone lesion from potential malignant masses with a high negative predictive value. So we leave MR for characterization of adnexal masses that are indeterminate ultrasound. So it's a problem-solving modality which has high sensitivity as well as specificity for identifying malignant and benign masses. CT really doesn't play a role except perhaps for characterization of dermoids in the, characterization of adnexal masses. But of course, many are found on CT, and it's really important, of course, in the staging of cancer. So what we'll talk about is illustrate key sonographic characteristics of benign lesions that we can readily diagnose, and review sonographic criteria that will help answer the question, is this mass likely to be an aggressive or invasive ovarian cancer, or is it likely benign? And we'll discuss some indeterminate masses, because all this is really important in terms of allowing us to formulate a clear conclusion and offer appropriate recommendations. And I will discuss them as we go along. So there have been three, it felt, at least in the US, we were tended to be a little bit all over the place, varying among practices of how to approach adnexal masses. And there have been three recent consensus papers that have been helpful in trying to encourage use of standard terminology and use rules to help us guide the masses. And these are the simple rules from IOTA, the International Ovarian Tumor Analysis. The SRU is more focusing on the adnexal cyst in their more recent paper. And then there is finally the ORADS from the American College of Radiology, which tries to be a very comprehensive management strategy to classify risk of an ovarian or adnexal mass being, malignant. And so I would encourage everybody to adopt at least some of them to try to make it uniform throughout your practice, especially if you have a very large number of radiologists, such as we have at NYU or we had at Hopkins. Because that will allow you to offer recommendation for management based on current evidence-based practice. Of course, we do that after discussion with the referring clinicians, but that will allow us to minimize unnecessary follow-up imaging and also referral to the appropriate specialist. So let's first talk about benign adnexal masses that we can readily diagnose. And the first one is an ovarian cyst in a premenopausal woman, which is more ovarian lesion, I should say, not really mass. And you have simple cysts, which is basically a failure of the follicle to involute, or hemorrhagic cysts, which is thought to be failure of the corpus luteum to involute. These tend to be symptomatic. And then, of course, a theca lutein cyst in cases of hyperstimulation or gestational trophoblastic diseases. So this is the most common lesion in 50 or younger women, a simple anechoic cyst. And the recommendation has changed a little bit recently. So if it's less than 3 centimeters, it's basically considered normal. Between 3 and 5 centimeters, the SRU guidelines suggest that you don't really need to do a follow-up in these premenopausal women. between 5 and 7 centimeters, if it's really simple, you can think about it, but most will recommend a follow-up in 2 to 6 months. And over 7 centimeter, definitely a follow-up and possibly suggesting another imaging modality, because above this size it's really difficult for ultrasound to be sure that this is a simple cyst. And this is just an example of a corpus luteum, which is, fluid vascularity around it that we all know about. And, this, because of this vascularity, that they can, sometimes bleed and become hemorrhagic cysts. Now, in an older woman, it's a little bit different. So this is a 76-year-old woman which has an adnexal mass. You see this about 4.5 centimeter. It's also completely anechoic with a thin wall. So it's a simple cyst. And if provided that it's unilocular, that has thin wall, there is no color Doppler or just high resistant flow at the edge of the cyst, we've seen that many of these women, screening of asymptomatic postmenopausal women, about 3.3 to 15% will have these cysts. And particularly 10% of postmenopausal women on tamoxifen will develop cysts. So it becomes a dilemma what to do with these. When do we need to worry about them? When we need to follow them? So the recommendations are that you check the C8-125. It's normal. If it's less than 3 centimeter and you're comfortable it's a simple cyst, you probably don't need to follow. Above 3 centimeter, you do 3 to 6 months for characterization, and then 6 to 12 months for growth. And then yearly afterwards, at least until stability is assured, is what the general recommendation is, because the natural history of these cysts is either they remain stable or they resolve over time. Now, if there is any of these, the cyst enlarges, or there are mural nodules or thick septations, then I would recommend perhaps before surgery at least get an MR with contrast, or also in cases where the patient is really anxious or unable to undergo regular ultrasounds, then you need to maybe, have MR or even laparoscopy. And in those patients that have these cysts removed, some of the pathfinding that have been reported as serous or mucinous cystadenomas, para-ovarian or endometriotic cysts that have gone dormant in these postmenopausal women, or hydrosalpinx. The only thing I would say is be very careful when you call this a simple cyst, especially in older women, because you can have reverberation artifact near the near wall, and that's fine. But sometimes this can hide nodule. And if you'll see in this case, this is not just reverberation, because you shouldn't have reverberation artifact in that corner. And if you turn on it actually in the corner, you see that there is a mural nodule. And this turned out to be a small ovarian cancer in a patient that had an elevated CA-125. So we really have to be careful before we call something a simple cyst. Now, sometimes if the cystic mass is more than 10 centimeters, and both the aorta and the ORADs will talk about size, and generally when the cyst is more than 10 centimeters, then something else needs to be done about it. But if you have a cyst that large with some of these features, predominantly cystic mass, no septations or a few very thin septation, no mural thickening, no flow or high resistance flow, then this is likely that it's at least very likely to be benign, and this patient may undergo an MR and then get a GYN surgery. And this turned out to be just a very large, benign serous cystadenoma. So these are some of those features then in the cystic lesion would favor the fact that this is going to be a benign cystic neoplasm. Now, we're all familiar with the next very common adnexal mass, which is a hemorrhagic cyst. If you see a retracting clot with these acute angles, or if you see this lace-like or fishnet appearance, they will be avascular, of course, because this is just a blood clot with maybe some flow at the edge of the lesion. And sometimes they can have a fluid level. In these cases, it's very easy, straightforward diagnosis. If they're 5 centimeters smaller, there is really no need to follow up. If they're larger, perhaps you want to do the follow up in 6 to 12 weeks to make sure they resolve. And it's the same rule if you see an ovarian cyst on CT in a young woman. You basically apply the same rule. You don't really need to get an ultrasound to follow up. If they have an atypical appearance, such as this one, which looks more solid, then of course you'll get a follow-up. And you can see that this patient came a little bit earlier than we suggested, but anyway, it had already resolved, or at least gone significantly smaller. Now, another lesion, so we can diagnose simple cysts, we can diagnose hemorrhagic cysts with confidence. Another lesion we can diagnose with confidence is endometrioma, which is basically functional endometrial tissue outside the uterus. And there's a diffuse form that basically forms scar tissue, but the chocolate cyst is what we're talking about here, which is a localized endometriosis of the ovary. And they have a very typical appearance. They can be multilocular or unilocular, but they all have this diffuse ground glass low-level echoes. And then the other thing that they can have septations, but the other thing to look for is these echogenic foci in the wall. That's very characteristic of endometriomas. It's basically probably debris from hemosiderin from the hemorrhage. So look for that if you think something is an endometrioma. And of course, if it's a large cyst, such as this one, is more than 7 centimeters, you can see again that this has a typical ground glass appearance. Then you may want to do an MR just to confirm. And basically, there will be high signal intensity on T1 because of their blood content. And there's a characteristic T2 shading that you see on T2, again, due to the hemosiderin content of these lesions. Now be careful again, because this lesion, if you look very quickly, also looks like there are diffuse low-level echoes. However, this one has nodules, right? So if there are nodules like these soft tissue nodules, then this is not an endometrioma. And this turned out to be a borderline serous tumor. Of course, this was also an older woman, so she shouldn't have an endometrioma to begin with, unless she's on some medication. But so be careful, make sure that you don't miss those nodules in the wall. Now, another lesion that we can readily diagnose is this one. This was a 56-year-old woman with breast cancer, so you can imagine that she was very anxious. But we can reassure her because this is indeed an ovarian mass, but it has this typical, so it's more solid appearing, but it has this typical echogenic lines within it, which is characteristic of a cystic teratoma dermoid. And this is the dermoid mesh. Now, these are quite common, probably one of the most common ovarian neoplasm. They can be bilateral. They mostly are seen in young adult and pregnant women, but 8 to 10% are found in postmenopausal women. And because they contain derivatives from all 3 germ layers, they have very characteristic ultrasound features. Dermoid mesh or echogenic mass with shadowing. And this is that's the only solid mass, if there is shadowing within a solid mass, this is part of the iota simple rule, that will also be a dermoid. They may have calcifications, and they may have some, other appearance such as a fat fluid level or floating echogenic balls. And if you have 2 or more of these signs, this is a really old paper, but it's hold true. This is 100% positive predictive value for the lesion being a cystic teratoma. So this is a small echogenic mass in the ovary, like a 2 centimeter, probably a small dermoid, really of no clinical significance. This is a lesion. That's why we have talked about a tip of the iceberg, son, because there is so much shadowing, and the shadowing in this case is probably from fat mixed with hair. You don't see the borders of the lesion. That's why it's called a tip of the iceberg. Now, sometimes they have less different appearance. So this is a lesion that has a fat fluid level with a hairball that floats at the fat fluid interface, and also the Rokitansky nodule here. And the CT confirms the presence of actually bilateral dermoids. This one is very large, but again, it has these floating hairballs, and this one also has this characteristic shadowing. So we can be pretty confident that this is going to be a cystic teratoma. And this large size perhaps might not be a bad idea, just to get another study such an MR to confirm. Plus, as we'll see in another talk, they are at risk for torsion. And this is, however, a very atypical appearance. This patient had pain. And really in this mass, it's a solid appearing mass, mostly solid, and there is no shadowing. So really in this particular case, we cannot be comfortable that this is a dermoid. And so we're going to get a CT, but also an MR with fat saturation, the T1 with fat that confirms that there is fat in this lesion. And this is indeed a cystic teratoma, but this is an atypical lesion. You would not be able to make a comfortable diagnosis on ultrasound. Now, again, be careful, because the nodule, if it's a cystic mass and there are echogenic nodule, you want to make sure that there is shadowing to call it a cystic teratoma. In this particular case, there is no shadowing, and this was a high-grade ovarian cancer in a actually young woman. So by her age, she really could very well have had a cystic teratoma, but there is nothing in this case. There are echogenic nodules, but they're not shadowing. Now, another lesion we can comfortably diagnose is a hydrosalpinx by its tubular appearance. And when you look at it on cross-section, you can see the thickened fimbriae. So that's an easy diagnosis to make. Now, again, here, now this one is, again, you can get a sense that it's tubular, even though portion of the fallopian tube is more distended. And this patient did have an MR that confirms the diagnosis. Again, she was 56 years old, so we wanted to make sure. But this is another comfortable diagnosis you can make. Another one is a para-ovarian cyst, which is a simple cyst, probably from one of these embryologic remnants in the broad ligament, so it's separate from the ovary. And of course, this is important to recognize that they're separate from the ovary because they're not going to change. They're not functional cyst, so you just have to call it a simple para-ovarian cyst. And then finally, peritoneal inclusion cyst is also a lesion that we can often comfortably diagnose. What it is basically is trapped peritoneal fluid, because the ovary will secrete some fluid, and because of adhesions around the ovary, the fluid will not get resorbed and will be trapped. Usually these patients have a history of prior surgery, pelvic inflammatory disease, or endometriosis. Usually a lesion of premenopausal women with active ovaries. And the important thing to recognize is that they have a passive shape. They don't create mass effect. They tend to surround the ovary, as you can see here. So to summarize, these are benign lesions we can diagnose with certainty. We can put it in our report and basically reassure the patient. Now, the next, of course, very important question is this ovarian mass. It's not one of these things we can recognize. Are they likely to be malignant? And so again, the performance of sonography in the hand of expert sonographers is really excellent. And what is very good is combining grayscale with color Doppler or grayscale with color and Doppler spectrum. And that's really the best way to characterize these ovarian lesions. So again, this is again, in the simple rule, lesions that are very likely to be malignant if they're solid and have vascularity, especially disorganized vascularity, or if they're cystic. So if they're cystic, you have irregular wall, thick septations, mural nodules, or papillary projections, or internal echoes. And always important, if you have a mural soft tissue, to look at the vascularity here, and you can see that there is, low resistance flow within this vascularity. And also if you have ascites, of course, and this turned out to be an endometrioid cancer. And vascularity is also important because what we're trying to do is confirm the presence of tumor vessels. They can be peripheral or in the central portion of the lesion. And these vessels are abnormal. They tend to lack smooth muscle. They tend to have AV shunting. And so they will have this forward flowing diastole with low resistive index. Now, some people use these measurements. I don't personally think they're very helpful. If you just look at the lesion, you don't need the color Doppler power, the Doppler spectrum to tell you this is likely to be malignant. So just look at the lesion and look at the Doppler spectrum. So this is another example of a solid mass. This patient actually presented with abdominal distension because she had ascites. That was her presenting symptom. So if you have ascites in an older woman, of course, that's also a very likely indication that the ovarian mass may be malignant. And so what we're trying to detect, of course, is invasive ovarian cancer, which is represent about 25% of gynecological cancers, usually affect older women, peak at 50 to 60 years of age. And it's really the fourth leading cause of cancer death in women, because unfortunately, most of the time, these are silent tumors that are diagnosed late. And we already talked about risk factor, the BRCA1 and BRCA1 and 2 gene and Lynch syndrome. And the vast majority are surface epithelial tumors, and the most common among them is serous cystadenocarcinoma, but there are mucinous cancer, although many of the mucinous tumors can actually be benign. And there's also other varieties such as endometrioid cancer and clear cell cancer.
The Airtel subscriber you have called.
Some problems people are having. Can't log in only.
What are the ancillary findings in ovarian cancer?
हमने मेरे को लिंक भेजना, हम लोग शेयर करते कुछ 100-150 जन cannot log in.
Other people have put their microphone. I'll just put that off.
अभी क्या करूँ? अभी थोड़ा 3 घंटा करने देखने दे मुफ्त
Look at the peritoneum. Oftentimes with
और मैं सोचता हूँ YouTube live भी कर दो, अभी क्या कर सकते हैं?
And you can see
at least
nodules and soft tissue. So this is carcinomatosis, and I think you can really detect on ultrasound if you're careful, or if the patient has implants in the spleen, as in this case. So these are subcapsular implants, and of course you can see omental caking very easily on CT. Now, what about this case? So this is a 26-year-old woman, and she has a mass that looked like the cystic mass, but there is a big nodule here. And again, she's young, right? So if you see a mass like this in a patient who is young, one of the things to think about is that the fact that this woman could have a borderline serous tumor. And that's what she had. So these are tumors of low malignant potential. And it's important to recognize, because in this patient, what they did was, because she was young and she, to attempt to preserve fertility, they just did a right oophorectomy at the time. And then she came 2 years later, and now we're looking at her left ovary, and she's a very small lesion. But if you look at the lesion here, this doesn't quite look like a hemorrhagic follicle, right? It is a little bit too nodular, and it has flow within the soft tissue, right? So this turned out to be a serous tumor in the contralateral ovary. But fortunately, in between the 2 years, she was at least able to have one child. So again, how to describe things really important in terms of management for these patients. So these represent about 15% of ovarian epithelial neoplasms. They tend to be mucinous, but they can be serous. There's no stromal invasion. They usually affect younger women. And again, in these patients, we have to think about the possibility of fertility preservation to try to do maybe less aggressive surgery, because the vast majority are FIGO grade 1, so they have a very excellent survival rate. Now, another tumor is a mucinous ovarian tumor. So they tend to be very, very large at presentation. As this case, it was almost 24 centimeters. They may have internal echoes, multiple locules and septations, little vascularity. And although you can have mucinous cystadenocarcinoma, the vast majority, about 80%, are benign. This is another example. They can look very, very complex. This was actually a young patient where we suspected ovarian torsion, and laparotomy, she had no torsion, but she had a benign mucinous ovarian tumor. However, of course, this is a mimicker of this lesion. This is bilateral. This patient had bilateral ovarian lesions. They look kind of like a mucinous tumor, but this was metastatic mucinous colon cancer. So ovarian metastases represent about 10% of malignant ovarian masses. The common primary tumors are colorectal, stomach, pancreas, breast, and lung cancer. The clinical history is key, of course, and this patient had not only this bilateral ovarian lesion, but she also had a echogenic mass in the liver. Now, to finish, I want to talk about ovarian masses that do not fit the previous pattern, right? So they're not clearly benign, they're not clearly malignant. So what do we do? And this is where MR really plays a critical role. So this is a good example. This is a 57-year-old woman with a palpable mass, and this is what we see in the left adnexa. Now, if you look at it, it is very hypoechoic, and there is some shadowing, right? So that's it looks like a fibroid, except it's in the ovary. So that's a very good probability that this could be an ovarian fibroma, which is a benign lesion, but you want to make sure that you confirm on T1 dark, just like fibroids are. And it's also T2 dark. And so the MR will confirm that this behaves. Also, if you do a diffusion and you do a contrast, that will again confirm that this is an ovarian fibroma. And so ovarian fibroma is part of the ovarian sex cord stromal tumors, which are less common. And they include fibroma and thecoma, granulosa cell tumor, and Sertoli tumors. They can be solid and hypoechoic, but they can also be large and cystic, particularly granulosa cell tumors. And again, MR increased specificity and help guide management. So this is another example of an ovarian fibroma. So hypoechoic mass with acoustic shadowing, dark on T1, dark on T2, and they can have some delayed mild enhancement post-contrast. And again, the surgery confirmed that this was an ovarian fibroma. But the thing is, in this particular case, we can tell the gynecologist it's likely to be an ovarian fibroma, and they may like to do laparoscopy, not do an open laparotomy, but a less invasive surgery. So this is an interesting case. This is a 62-year-old woman with had a history of hirsutism and high serum testosterone. And so if you look at her right ovary, she has a very small lesion, but it's very vascular at the edge with this, low resistance flow. And what this turned out to be at surgery was a benign Sertoli-Leidig tumor, which is the most common virilizing ovarian tumor. So what is the value of color, to summarize? Well, I think it's really sometimes helpful, not just in showing the tumor vessels, or very high resistive flow in benign lesion, but in differentiating cystic from solid mass. If you look at just a grayscale between this fibrothecoma and the endometrioma, they don't look that much different. But if you see the color here, you can see that there is flow within the lesion. So this is not going to be a cystic lesion. This has to be solid. Versus here, there's only flow at the edge. So I think this is how I think sometimes that color is really helpful in these kind of difficult borderline cases. And finally, are we always right? Well, this was an 88-year-old woman who had a CT scan first for abdominal pain, and they saw this kind of aggressive-looking lesion in the right adnexa, enhancing REM. And so, they thought it was an ovarian mass. And on ultrasound, the ultrasound was really not much better than the CT. You see the same, like a cystic and solid mass. And again, we thought that was an ovarian cancer, most likely. But fortunately for her, it turns out to be an appendiceal abscess which had ruptures with focal perforation. And perhaps we could have picked up on the ultrasound that there was a loop of bowel intimated related to this. Anyway, it was lucky for her. So, in summary, I hope I've shown you that it's really important to offer a specific diagnosis when you can not just say this is a mass and it could be anything. It's really what we need to tell the clinician is that it's an ovarian mass, something we can readily diagnose and it's a very common thing, or is it likely benign, or could be an ovarian invasive ovarian malignancy, because there are really critical management implications. For indeterminate mass, I would recommend an MR. If you suspected an ovarian cancer on ultrasound, they can go directly for CT for staging, Also, whether the patient should be referred to a gynecological oncologist if you're suspecting it's a ovarian cancer, whether you can do laparoscopy versus laparotomy. So if you think it's a fibroma, laparoscopy is probably okay. If you think it's an ovarian cancer, obviously the patient will need to be referred to a tertiary center to undergo laparotomy. And also think about possibility of preserving fertility in younger women. So our role is really to help tailor management to the individual women, and that's what we need to put in our report. And so I thank you for your attention on this case, and then we're going to move, if that's okay. Are there any questions?
No, ma'am. Right now there are no questions.
Okay, so then we will move to the next talk. And so here, we're going to talk about evaluation of the big and bulky uterus. So enlarged uterus is really one of the most common indications for gynec ultrasound. And so what we'll do in this case is we'll really focus on pathological processes that affect the myometrium, because primary endometrial abnormalities rarely present. They may present with vaginal bleeding, but they rarely present with enlarged uterus on physical examination. And so the first question, the most common question we often need to answer, is that adenomyosis or is that myoma? Because both are very common pathological conditions that affect women of all ages. They're often asymptomatic, but if you have symptoms, they can have pelvic pressure, they can have menorrhagia, occasionally severe enough to cause anemia, or they can have dysmenorrhea, particularly with adenomyosis, and they sometimes may have reproductive dysfunction, for example, in submucosal myoma. And so we'll talk about the globular, bulky, or lobulated uterus. Now, in adenomyosis, and we used to, up to several years ago, we used to really not be focusing on the difference, but it's really a different process. In adenomyosis, there is chronic disruption of the basal endometrium to myometrium boundary, the junctional zone. And so the endometrial glands and the stroma migrate in the myometrium. And as these glands bleed cyclically, they cause hypertrophy and hyperplasia of the adjacent myometrium. And it can be a diffuse or focal process. By contrast, myomas are benign smooth muscle tumors that contain variable amount of smooth muscle and fibrous tissue, and they have a pseudocapsule. So they should be well defined, and their growth is estrogen and progesterone dependent. So this is the pathology of adenomyosis. You can see that there are no borders to these lesions, and we'll talk about the ultrasound appearance. By contrast, myomas all are well encapsulated, and so they should present as well-defined lesions. In my mind, there is no such thing as an ill-defined myoma. So what's really important, because the uterus is very large, I think doing a transabdominal ultrasound is really helpful because sometimes in large lesions, it's hard to see the borders and it's hard to penetrate just with vaginal examination. The 3D coronal reconstruction really help in evaluating the junctional zone, which is right there at the border between the endometrium and the myometrium. And finally, in the US, we don't do ultrasound ourselves. Oftentimes we depend on a sonographer. So I think having cineclip is really important to appreciate the echotexture of the myometrium that you may not be able to detect so well on still images. So a few numbers. Ultrasound has pool sensitivity of 84% almost and specificity of 64% in differentiating adenomyosis from myoma. Of course, it depends on the expertise of the person doing the ultrasound. And so what are the findings? So in adenomyosis, there are findings related to ectopic endometrial glands in the myometrium, and you'll see echogenic nodules or striations emanating from the endometrium into the myometrium, or you can have cystically dilated glands that will present themselves as myometrial cysts, or lollipop diverticuli extending from the endometrium into the myometrium. And you may see, just like you see on MR, the ill-defined thickened junctional zone. The smooth muscle changes that are due to the smooth muscle proliferation caused by adenomyosis. You may have asymmetric myometrial thickening with ill-defined borders and coarse echotexture of the myometrium with this Venetian blind appearance, this kind of streaky shadowing coming from the myometrium. And you can have vascular changes. There may be increased vascularity, and you can have penetrating myometrial vessels. So let's look at the example. These are some of these smooth muscle changes. This is an enlarged sort of globular uterus and you can see here that there's this streaky shadowing from the posterior myometrium, the Venetian blind, and this MR here confirms marked thickening of the junctional zone in this patient with adenomyosis. The patient presented with pelvic pain. Another example, these are the endometrial glands into the myometrium. You can have these echogenic nodules. You can have these cystic areas and these lollipop type cystic areas extending from the endometrium into the myometrium. And sometimes you can see these echogenic lines that are projecting from the endometrium into the myometrium. You can see it very well on the coronal 3D reconstruction. Again, same patient with the video clips that I think is very helpful to see all these echogenic nodules as well as cystic changes in this patient with extensive adenomyosis. Again, this is a more subtle case, but what you see here is thickening of the junctional zone. And on the clip, you can see the cystically dilated glands in the subendometrial region right there, and the corresponding MR showing the adenomyosis. This is a more subtle case. All you see here is sort of asymmetric thickening of the myometrium with kind of an echogenic areas. You can see the penetrating vessels here. And again, thickened junctional zone on the MR.
Thursday, all hiccups will be there.
And then again, if you want to contrast the vascularity of adenomyosis, you can see these penetrating vessels in the myometrium versus in myoma, the vascularity will be kind of displaced surrounding the lesion. This is an interesting case. This is a cystic adenomyoma rare. This is an 18-year-old woman which had a history of pelvic pain. And basically what it looks like, a cystic lesion in the myometrium that looks like endometrioma. And it's not surprising because what happens is that basically it's a cyst which is lined with endometrial gland and stroma, and it undergoes cyclical bleeding. And so this case was actually confirmed by aspiration. It's a rare lesion. They're basically just case reports in the literature. Now let's talk briefly about myoma, and what we'll talk about some more problem cases. But basically they cause mass effect, and the smooth muscle changes will have a world appearance. You can have shadowing because there's a lot of fibrous tissue sometimes in those myomas. They will cause mass effect, and the vessels will be displaced. So this is a classic example. Everybody will make this diagnosis, but the problems is whether it's location, atypical ultrasound appearance, and what do we do when there is growth of a myoma. So location is of course key. So you have subserosal, intramural, but the one we are some more concerned about because they can cause problem on these patients is the submucosal ones. As you can see here, okay, so this is it's playing the endometrium, but it's classic appearance of a myoma. Otherwise, it's hypoechoic with shadowing. And what we need to try to tell the clinician whether it's less than or more than 50% intramural, because if they are predominantly submucosal, then you can do just hysteroscopic removal, versus if not, then they may need myomectomy. So that's why it's important to try to localize the submucosal myoma correctly, and sometimes the 3D again will help. In this particular case, it's more than 50% submucosal. Sometimes they will cause issue. This is a 37-year-old woman who presented to the emergency department with very heavy vaginal bleeding, and on examination, there was a mass protruding in the cervix, and sometimes they're really difficult to diagnose because, with the vaginal probe, you're so close to the area of interest, but you can see here that there is a mass in the cervix. You can see the vessels leading to this mass. And sometimes I found that transperineal scanning, when you put the transducer on the patient's labia, would be helpful, because here you see the transducer is here. This is the vagina, and you see this leiomyoma that is kind of try to, protrude himself, try to basically deliver itself through the vagina. And these patient underwent an emergency histoscopic resection because she was, markedly anemic. Now, the other dilemma we can have is that a submucosal myoma or is that a polyp if you see predominantly endometrial mass? So leiomyomas we tend to be hypoechoic, may have shadowing, tend to have a broad attachment to the myometrium, versus endometrial polyp tend to be more echogenic. They may have cystic spaces. They can have a stalk or broad attachment, one or the other, but they often have a feeding vessels. And of course, saline infusion can be very, very helpful. So we have two examples. This is a leiomyoma, submucosal, and you can see it has a broad attachment. It's also hypoechoic with some areas of shadowing, versus this lesion here. And when you do the saline infusion, you can clearly see that it has a relatively narrow attachment. There are actually multiple polyps. And if you put color, you can see that there is a feeding vessel in the endometrial polyp. That's also pretty characteristic. There's some pitfalls, especially if you have a very pedunculated myoma. You want to make sure that, how you measure it and whether it's included in the measurement or not. And I have seen people miss exophytic pedunculated fundal fibroids or very lateral because they don't bother scanning above the uterus. So it's really always important to scan above the uterus to make sure we don't miss a large fundal fibroids, which is exophytic, or the ones that are in the broad ligament can mimic a solid adnexal mass, such as an ovarian fibroma. So for example, here, there's all this is the uterus here, this is the adnexal mass. Is that a myoma or an ovarian mass? Now, one of the things you can use is the bridging vessels. If you see bridging vessels going from the uterus into the lesion, it might be a sign that this is more likely to be a pedunculated fibroid. But I think in this case, it's really helpful to have an MR that shows that these are basically pedunculated fibroids. In this case, it's really on ultrasound, I think it can be difficult sometimes to make the distinction between pedunculated myoma and ovarian lesion unless you see the ovary separate from it. Of course, the first thing to do is try to find the ovary separate from this lesion, and then your work becomes a lot more simple. So again, so here we see this lesion here, this lesion here. So these were actually ovarian fibromas. You can see that it's part of the ovary with a hemorrhagic cyst. But again, MR is helpful. You can see the uterus is normal, but there is this low signal intensity lesion. That's the ovarian fibroma. Now, what happens? So they can have a typical appearance, particularly if you have degeneration. And what happens is when they overgrow their blood supplies, they can have various types of degeneration, either hyaline, myxoid, cystic, or hemorrhagic. And they really have a variable appearance on ultrasound. They may have calcifications, that's fine, we see that all the time, but they can be cystic or they can be echogenic. And these are the ones that rarely, but sometimes cause acute pain. If you have acute degeneration of myoma, and this can happen sometimes in pregnancy in particular, that's one of the times when myoma can cause pain. Otherwise, they usually don't cause pain. They can cause vaginal bleeding, but no pain. So these are examples of a cystic degeneration. So this is a cystic lesion in the uterus, not a typical appearance for myoma. This patient also happened to have a left ovarian dermoid, but you can see here on the MR again this cystic degeneration with no enhancement, but just no enhancement in the cystic portion, but enhancement in the rest of the fibroids. And I think in these cases, having an MR to confirm the diagnosis is really, really helpful. Sometimes, and this is a patient who presented with back and pelvic pain. This is a more echogenic mass. And the patient had a CT actually initially because of the pain. And you can see here that this myoma doesn't enhance the way they should enhance normally, again, because of the cystic degeneration. That's probably why this patient had pain. And then there is this unusual lesion. It's a rare lesion, a lipoleiomyoma, which is a rare fatty benign tumor, typically affect peri or postmenopausal women around 45 to 55. And what they look like is a very echogenic mass with some areas of shadowing within the uterus. It basically looks like a large cystic teratoma, except it's in the uterus. And so this is a lipoleiomyoma on ultrasound, and the CT here, which was actually done prior to the ultrasound, confirmed the fact that this is a predominantly fatty mass. Not a common lesion, but something. This was actually an older patient, 76-year-old. What happens? What should we do if you see growth over time? So we know that these lesions are estrogen and progesterone dependent, and the growth can be associated with pregnancy, end-of-ovulatory cycles, tamoxifen treatment, or degeneration. And they can grow, especially during the 5th decade of life. So the rate of growth, that's the other complicating factor, is the rate of growth doesn't really correlate with risk of leiomyosarcoma. But we know that they should regress after menopause. So if you see a very large uterus, and we'll talk about in a few minutes, in an older woman, then we have to worry about the presence of leiomyosarcoma. So this is a symptomatic enlarging myoma. This is a 36-year-old patient who presents with acute abdominal pain. And the fibroid here that we see here had increased from 3 centimeter and on a prior CT for 9 centimeter in a more recent CT. And of course, then we were really quite concerned about it. But at surgery, what happened was, and that's probably why she had the pain, she had benign myoma with torsion and necrosis. We all were worried that it was a leiomyosarcoma because of the very rapid enlargement. Turns out that probably because she had torsion and necrosis, it enlarged. Who knows? So a couple of technical tips. If there is marked uterine enlargement, best image with transabdominal ultrasound. At least in the US, everybody always wants to rush and do as many patients as possible. And sometimes these patients come with a script of only doing transvaginal ultrasound. And if the patient has a large fibroid, I always insist that please get a few pictures with transabdominal to better appreciate the extent of the lesion. This is a very large fibroid that extended up to the patient's umbilicus. But if you see a very large uterus, you have to think about a differential diagnosis. Could be myoma, could be leiomyomatosis or metastatic leiomyoma, or it could be malignant tumors, which are of the myometrium, which are rare but can happen. And this includes sarcoma, metastasis, and very, very rarely lymphoma. So when we think about uterine sarcoma, first of all, they're very uncommon. The vast majority of leiomyosarcoma, but there are also these carcinosarcoma, malignant mixed Mullerian tumors, which occur in older women, or also PNET. And basically what they do is that they can mimic fibroids on imaging, particularly on ultrasound. And MR is the best imaging modality, particularly if you see restricted diffusion. But I would suspect sarcoma if there is rapid uterine enlargement, or if there is a very large bulky uterus in an older woman, or if there are metastatic nodes or nodules. So look around, look in the groin, look for ascites, or if the patient, of course, has lung metastasis or other more distant disease. So I'll just show you a couple of examples. This was a very large uterus, almost 19 centimeter uterus in a 68-year-old woman who had postmenopausal bleeding and a negative endometrial biopsy, because of course it wasn't the endometrium that was affected. And she had this very large heterogeneous uterus. But what we saw in addition to this is this left inguinal region mass here. And so we know then that it is very likely that it's going to be a sarcoma. And it turned out to be a high-grade sarcoma. And look about this lesion. I'm sorry, this was a young woman, 36-year-old, with, again, very, very large uterus, 24 centimeters, heterogeneous, but otherwise, again, in a young woman like this, you wouldn't necessarily think about, sarcoma. So we just say she had fibroids, and she had persistent cough. And then a few weeks later, she had a CT scan for persistent cough, and long and behold, she had all these lung, pulmonary, and fourth-line metastases. And again, on the PET CT, you can see the very large uterus, and there is a lot of duration already, so the PET is just positive at the edge, but she had positive lung lesions. Unusual case in a very young woman. Carcinosarcoma is another lesion that will present with enlarged uterus. This is a 76-year-old woman with postmenopausal bleeding and a rapidly enlarging uterus. And quite frankly, it is really difficult to tell the difference on ultrasound. And the tumor in this particular case originates in the endometrium, so it's going to be centered over the endometrium, but they often also present with a bulky uterus. Now, most patients with regular endometrial cancer, as you can see here, don't present with enlarged uterus. They will present with postmenopausal bleeding. And this is just a typical appearance of a basically normal-sized uterus with markedly thickened, hypervascular endometrium that you're going to see in your run-of-the-mill endometrial cancer. Occasionally, you can have metastatic disease to the uterus. This is the only case I've ever seen, actually, so it's pretty uncommon. But this is a patient who has rapidly enlarging uterus with heterogeneous lesions on ultrasound, perhaps better seen on CT here, hypervascular, and she had a history of breast cancer, so I don't have proof of it, but we just kind of presume that this was a metastatic disease to the breast, very, very uncommon. So the take-home point is that adenomyosis and myoma both are very common conditions, and oftentimes they can coexist. An endovaginal ultrasound has high accuracy for diagnosis, but beware of the very large uterus, especially in older women, because you may be dealing with a leiomyosarcoma. And MR is really, again, just like in the nexal mass, very helpful for difficult cases or for treatment planning. Okay. Are there any questions?
No, ma'am. Right now, no questions. I think they'll be all coming together after the entire set of pictures.
Okay.
Yeah.
All right. So we will move to the next one. Okay, so this is, I'm going to talk about acute pelvic pain. So patient who present with pelvic pain in the emergency department, and we're going to do it a little bit differently. We're going to do case-based because it may be a little bit more fun. So first of all, let's start with a few definitions. Pelvic pain is really common. It accounts for about 39% of visits, either in the emergency department or in a doctor's office. And the definition is of acute pelvic or lower quadrant pain is a non-cyclical lower abdominal pain of less than 3 months duration. And we won't talk so much about vaginal bleeding because we'll focus on pelvic pain. And most of the cases I'm going to show you happen in women of reproductive age. So how is imaging so critical in these patients? Because, the clinical diagnosis in these patients really very, very difficult. So this was a 31-year-old woman who had right lower quadrant pain, presented to the doctor's office, and so the doctor sent her for a pelvic ultrasound. And she had a right ovarian cyst, but now again, when you do it yourself, it's easier, but we have sonographers, but we've trained our sonographers very well to always ask the patient, where does it hurt? And the sonographer asked, and the patient said, well, it doesn't really hurt down in the pelvis. It hurts right here in the right lower quadrant. And then so she saw these lesions, and then we went in the room, of course, and if we put the linear transducer, you see that actually there is a blind-lining loop with an appendix on it. And this patient had perhaps two reasons to have right lower quadrant pain. She had a hemorrhagic cyst, but likely the reason of her pain was acute appendicitis. And imaging was very helpful in triaging these patients because she didn't need just symptomatic treatment. She actually needed a general surgeon. So we play a critical role in triaging patients for the most appropriate management, which is it observation, reassurance, and symptomatic treatment? Is that GYN referral? Or is that referral to general surgery or even urology? And I will also talk a little bit about the CT findings, because despite the fact that in these patients of reproductive age having pelvic pain, the ACR guidelines recommend a pelvic ultrasound first. Some of these patients, unfortunately, too many sometimes, get a CT first. So let's talk about this patient. This is a 20-year-old woman with acute left lower quadrant pain and syncope. And of course, you start scanning and there is a very kind of worrisome picture, right? Because here's her uterus, she has large amount of complex fluid in the abdomen with this amorphous material that of course is clot. And if we look even by Morrison's spout, there is some fluid up in the upper abdomen. So what's going on? So the other, of course, important thing is that this patient had a negative pregnancy test, right? Because if she has a positive pregnancy test, we think about ruptured ectopic, we're done. She had a negative pregnancy test. And when we did the vaginal ultrasound, we saw that the right ovary is normal, but there is, again, complex fluid, but there is this amorphous material around the left ovary, which we cannot even recognize. And so basically what this patient had was, and then she had a CT, but what we said was she has a ruptured hemorrhagic cyst with hemoperitoneum. And the gynecologist wanted to get a CT just to look at the extent of the bleeding. And you can see again on CT, you'll see the same findings. She has a hemorrhagic cyst, but with a clot right next to the cyst. It's always a good sign that this is a thing that bled. And she had very extensive clot in the pelvis as well as hemoperitoneum in the rest of the abdomen. So she was admitted for observation. She became stable, so she was managed conservatively. So hemorrhagic cyst with hemoperitoneum occurs when there is significant hemoperitoneum hypovolemia. Of course, we have to exclude ruptured ectopic pregnancy. These patients have negative HCG. And it's not common, of course, but we see maybe once or twice a year. I've seen it once or twice every year. It's more common in women that are on anticoagulant therapy. And it's important to recognize this. And then these patients usually generally will be admitted and will be observed. If the patient is stable, they will just be observed. Occasionally, they will have to go in and evacuate the hemoperitoneum. But what we're going to see on ultrasound is clots in the pelvis, echogenic fluid, and hemoperitoneum or ascites in the upper abdomen, and high density clot in the adnexal region on CT. And of course, CT is also helpful to exclude other causes of hemoperitoneum, such as, for example, a ruptured hepatic adenoma. So the most common cause of actually acute pelvic pain is a ruptured hemorrhagic cyst, but that doesn't cause hemoperitoneum, just cause a little bit of blood in the pelvis. As you can see here, this is echogenic fluid next to the ovary, again in a patient with a negative pregnancy test. And these patients present with acute pain because of the peritoneal irritation caused by blood. And oftentimes by the time they've waited for you to do the ultrasound, they all often, get better on their own. And the typical presentation is they were exercising or had intercourse and all of a sudden had acute pelvic pain. So it's important in this particular case to be able to reassure the patient, offer symptomatic treatment if you need, and then the patient can get better on their own. This is another example of hemoperitoneum. Again, large amount of blood clot in the pelvis and in the right lower quadrant in this transabdominal ultrasound. You can see the clots nicely. on the endovaginal ultrasound, and then on the CT here, this patient was kind of becoming hypotensive, and that's why we sent her to CT. And you can see here that there is active bleeding on this arterial phase CT from the ovary right there. Okay, so this is another entity. This was a 44-year-old woman with severe abdominal pain. And she first had a CT scan that basically showed 2 adnexal masses, one of which with thick wall, and this kind of strange, very marked but localized fat stranding just anterior to the mass. And you can see it here on the axial, and you can see it here in the coronal. So she went to ultrasound after the CT, and here are the lesions we see. So if you see the lesions, especially the small one, you can see this echogenic foci in the wall, and this really looks like endometriomas, right? But the funny thing is that usually patients with endometriosis may have chronic pain, may have dyspareunia, but they don't have usually acute pain. So this being the US, we can, all the imaging we could. So she also had an MR. And again, on the MR, you can see bright on T1, T2 shading, so classic endometriomas. But again, you can nicely see what you cannot see on ultrasound, of course, is this kind of very nodular fat stranding that's localized around this endometrioma. And what this patient had was ruptured endometrioma with adhesions. Okay, so this is a rare case where endometriomas will cause acute pelvic pain. Now, ruptured endometrioma is an uncommon complication. They have severe pain because of the peritonitis. It can mimic ovarian torsion clinically. What you'll see again, suspect it if you have a thick wall of the endometrioma should not have an asymmetric thick wall like this, and if you have this focal fat infiltration. This is another patient who came with intermittent pelvic pain. She had a very, very large endometrioma. Again, typical ground glass appearance. But again, thing to remember is that endometriomas usually don't cause pain. So either there's torsion, which is not that common with endometrioma because oftentimes these patients have adhesions, or this ruptured endometrioma. Now this patient is 25 years old. It was her 3rd episode of left-sided pain in the past 6 months. She had no adnexal mass, and she came in with sudden onset of left flank pain and left inguinal pain and 1 episode of vomiting. So she had a CT scan first, and here's her CT. So you see this cystic mass in the cul-de-sac with some fat stranding. And again, you see this mass right there, but it seems like you see both ovaries on the coronal as well as the axial CT. So she had an ultrasound. So on ultrasound, here's a mass in the cul-de-sac with this weird kind of debris floating around. No flow really to speak of. This is just artifact at the edge. But then when we saw, it looked like torsion, but when we looked at the ovaries though, the right and the left ovary were both completely normal in size, and we could see flow. So what's going on? Well, and this was suggested, it wasn't my case, was one of a very astute colleague who suggested, that this is likely to be isolated adnexal torsion. And this is what happened at surgery. She had a 6-centimeter fluid-filled cyst at the distal end of the tube. The tube appeared dusky and purple and was twisted 360 degrees. It was untwisted, but ultimately they ended up doing a left salpingectomy with a large paratubal cyst that was removed. And it's likely that this paratubal cyst predisposed the fallopian tube to torsion. So isolated tubal torsion is really uncommon. It's often misdiagnosed. Predisposing factor is hydro or hematosalpinx, the presence of paratubal or para-ovarian cyst or adhesions. And on ultrasound, this is what you're going to see. The ovaries are going to be normal, but there is a cystic mass adjacent to the ovary in a patient who has usually severe pain with symptoms mimicking ovarian torsion. Sometimes you'll see a thickened fallopian tube, and if you really think about the diagnosis, try to find the whirlpool sign of the twisted fallopian tube. Okay, this would be a more classic example of ovarian torsion. This is a 40-year-old woman with low abdominal pain. She had this very large ovarian mass that looks like, for all the world, like a cystic teratoma, where there's a mass with shadowing. There's this dermoid mesh right there. But look at the position. It's above the uterus, and the patient has pain. So what we're going to do is try to find the twist. And if you look at the edge of the mass here, you see this knot right there. It's relatively avascular in this case. And so this is the twisted pedicle of a torus dermoid. And again, this is so we see the dermoid here, which is discolored. It's purple because it's necrosed, but you're also looking in between the uterus and the mass of this, like the twisted pedicle. So what are the ultrasound findings in ovarian torsion? Well, you're going to see an enlarged heterogeneous ovary. You may or may not see a mass, because oftentimes this patient will have a mass which add at the lead point of fulcrum for the torsion. If there's no mass, you're going to see peripherally displaced follicles. Sometimes they have an echogenic rim because there is edema around the follicles. Think about torsion if the position of the ovary is unusual, either in the cul-de-sac or flipped above the uterus. And again, in these cases, look for, and you have to search for it, for the twisted pedicle, which will appear as a target of whirlpool appearance. Oftentimes, a patient will have exquisite focal tenderness over the torsed ovary. And we'll talk about the Doppler signs a little bit later, but unlike the testicle, the Doppler signs in ovarian torsion can be variable. And the gray scale is really the most important finding. So let me show you a few cases. This is a 50-year-old with pelvic pain. So that she's a little old. Usually ovarian torsion happens in slightly younger patient. But she had this mass, solid mass in the cul-de-sac. And if you look at paid attention to prior lecture, it's a hypoechoic mass with shadowing. So it looks like a fibroma, but this position in the cul-de-sac really somewhat unusual. And here's again the twisted pedicle. So she also had a CT and an MR. And again, there's a little bit of a fluid, so that's always worrying when there's fluid, that this could be torsion. And so what she had was a torsed ovarian fibroma which infarcted. This is a 29-year-old woman which has multiple emergency room visits for pain. And if you look at the ultrasound, so there's a lesion in the cul-de-sac, and this has all the classic findings of ovarian torsion with the peripheral follicles with echogenic borders, but this was in an outside hospital, and they were confused by the fact that there was flow in the ovary. So they didn't think about the diagnosis of torsion because of the flow. And if you look at the CT, she does have signs in CT that also should make you think about torsion. You can see that the ovaries in the cul-de-sac is not enhancing normally. There is ascites. There is tilting of the uterus towards the side that's torus. That's another sign on CT. And here is a twisted pedicle. And perhaps you can see that twisted pedicle a little bit better on the coronal reconstructions. So this is to say that the Doppler findings in ovarian torsion are variable. Oftentimes there is no flow, of course, but sometimes you may have a little bit of flow, and sometimes, that is the only case I've seen, this is an old case, but this patient had recurrent pelvic pain, an ovary that just looks like ovarian torsion, but she had increased flow. And so I told the gynecologist, it still looks like ovarian torsion. I don't understand why she has increased flow. So she went in, and indeed the ovary was torus, but she figured maybe it was torsing, detorsing, and there was some reactive hyperemia. Now the other thing, the flip side is, so the gray scale in ovarian torsion is really the most important finding, in my opinion, provided the patient has the appropriate symptoms of, pain, nausea, sometimes vomiting. But if you see a normal ovary with no flow, usually that's technical. Because in ovarian torsion, if you think about the mechanism, you have twisting of the pedicle. So you have first obstruction of venous venous outflow. And so the ovary enlarges and becomes edematous. And ultimately, if there is enough twisting, you have also absence of ovarian inflow. And so you have necrosis as well. So you have a combination of edema, hemorrhage, and necrosis, and therefore the ovary usually is enlarged and usually is abnormal in echo texture. So again, just to recap, the CT findings in ovarian torsion: enlarged, hypoenhancing ovary more than 6 centimeters. Usually, think about it, the ovary is in an unusual position, either in the cul-de-sac or above the uterus. If it's a cystic mass that is acting as a fulcrum, you may have asymmetric wall thickening, you may have a lack of septal enhancement, you may have deviation of the uterus towards the sign that the ovary that is twisted. And again, as I showed you, you see the twisted pedicle on CT, and you can have complex focal ascites. The other thing is again, this is another case where the sonographer, they had ordered a renal ultrasound, but the sonographer asked the patient, where does it hurt? And it hurt over the ovary. So this was a patient who was pregnant with twins. And so if you look at the ovary here, it's a little bit large. And the follicles are a little peripheral, and her other ovary was not as large, and the patient was focally tender there. So then we went in to try to find out what was going on. And again, if you look for it, you'll see the twisted pedicle right here between the uterus. Here's the placenta and the ovary, which is clearly enlarged. The other thing is, in patients who are very thin, it's helpful to use a linear transducer, because you see the echo texture and you see the multiplicity of follicles in the ovary much better with a linear transducer. Here's the twisted pedicle in color. The other important thing here is that the ovary was enlarged and the patient had pain, but it wasn't as abnormal in echo texture, the cases I showed you first. So we told them, maybe this ovary is still viable, right? So they went in the OR very, very soon after the ultrasound. And you can see here that the ovary there is twist, but first of all, the twist wasn't as tight, and the ovary is still viable. It's not purple. So they detwisted the ovaries, detwisted, and the patient went on to deliver her twins and was okay, and they were able to salvage the ovary. Now, another case of abdominal pain and distension, we'll all be able to make the diagnosis here, because this is a 39-year-old woman who had very large bilateral ovaries. And again, if you ask her history, she's going to say, yes, I've been treated for infertility. And this is a case of hypostimulation syndrome, which when present with pain, these patients may be at risk for ovarian torsion because of the size of the uterus, and they may have ascites and abdominal distension if they have hypostimulation syndrome, which this patient had. So usually iatrogenic patients who have polycystic ovarian syndrome are at higher risk. And these patients can get into trouble, not just because of abdominal pain and distension, but they oftentimes have third spacing of fluid, they can have electrolyte imbalance, they can have extravascular fluid accumulation. And the ultrasound findings, which I just showed you, markedly enlarged uterus, ovaries with multiple cysts, ascites, and also look for pleural effusions. Okay, so another case now. This is a 46-year-old woman with pelvic pain, groin pain, and fever. And I'm sorry, this is a very old case, but this is, at least in the US, it's not a common finding. So that's the only case I could find. But on the transabdominal ultrasound, you can see here the uterus, you can see a vague adnexal mass. And she had groin pain, remember? So we looked in the inguinal region, and she had this kind of ill-defined fluid collection. So we weren't exactly sure what was going on. We got a CT, and on CT, it's not that much more clear. She has this kind of complex stuff going on in the adnexa, and she has a little bit of, which we didn't see on the ultrasound, a retained fragment of IUD. And so what this patient had pelvic actinomycosis. And actually, I I saw a case more recently. Now, indwelling IUD is a risk factor. They usually present with low-grade infection, and this is an infection that is kind of not as, kind of indolent, but this is an organism that goes through tissue planes, so the patient may have multiple pelvic abscesses. I've seen abscesses with actinomycosis even in the right upper quadrant of the abdomen, and it can really mimic clinically as well as on imaging ovarian or tubal cancer. So just something to be aware of. You have a patient that has had a long-standing IUD, indwelling IUD, usually more than 10 years, and think about the possibility of pelvic actinomycosis. Because if they go in also, the surgery can be very difficult because there are a lot of adhesions and really can be very, very messy. Of course, let's talk about more common pelvic inflammatory disease, which is a very, very common cause of acute lower abdominal pain. Classically, patients will have fever, vaginal discharge, cervical motion tenderness. And basically, it is usually a sexually transmitted ascending infection from endometritis, progressing to salpingitis and pyosalpinx or tubo-ovarian abscess. The most common organisms are chlamydia and gonorrhea, but oftentimes in reality, it's probably more microbial infections. Now, other infection, I'm saying here TB is less common, but probably not everywhere in the world. It's less common in the US, and I showed you already an example of actinomycosis. And the other thing is, in some patients, particularly if you have a GI inflammatory bowel disease, you can have spread to the adnexa from the inflammatory bowel disease, although that's, of course, much less common. So these are just some classic pelvic inflammatory disease ultrasound findings. So oftentimes, if the disease is mild, the ultrasound can be normal or just show kind of mildly enlarged ovary with indistinct border. Perhaps you can see a thickened fallopian tube, or you will see in pyosalpinx a tubular structure with thick wall, internal echoes, thickened fimbria of the fallopian tube. And again, always look for the fat. The inflamed fat on ultrasound is echogenic. So you have inflamed fat and increased vascularity. And then if the mass is engulfing the ovary, then you have this large complex mass, which you cannot recognize the thickened fallopian tube or the pyosalpinx because it has engulfed the ovary as well, and it's called a tubo-ovarian abscess or complex. An ultrasound is very good to make the diagnosis, and oftentimes this patient will have percutaneous surgical drain, and then they will have a CT just for treatment planning. How about this patient? This is an 18-year-old woman with right lower quadrant pain, fever, 7 days postpartum. And so we were concerned about appendicitis, and here there is, on ultrasound, there is this tubular structure, not compressing with increased flow around it. Didn't quite look like classical appendicitis, so we got a CT. And on CT, it doesn't look like appendicitis. It's more like a phlegmomatous mass in the right adnexa. And I have to say, this is again an old case. We didn't really make the diagnosis pre-op. We thought, well, maybe it's just some phlegmon. We weren't sure exactly what's going on, but we should have known 7 days postpartum to think about the possibility of ovarian vein thrombosis. And that's what she had. She had septic thrombophlebitis of the right ovarian vein. And of course, this is something that can happen postpartum. Now, unless you think about it, the ultrasound diagnosis is going to be difficult. You look for a tubular mass anterior to the psoas muscle. For some reason, it's more common on the right side. And the etiology is septic thrombophlebitis, either postpartum or after severe PID. Sometimes you see gonadal clot in patients who are hypercoagulable state, or sometimes you see asymptomatic ovarian vein clot in patients who are on chemotherapy. And of course, the differential diagnosis in patients with septic ovarian vein thrombophlebitis is acute appendicitis. And so here's a case. So this is again a patient who had right lower quadrant pain. So not all pelvic pain is going to be GYN in origin. Here her ovary is normal, but we see here this gut signature because you have an echogenic mucosa and the hypoechoic submucosa muscularis layer here. And this is the appendix with, again, echogenic fat surrounding it. So in this patient, the patient had a long appendix that was in the pelvis and were easy to see on the endovaginal images. So how do you tell the difference between, especially for the residents that are not used to, seeing as many cases as we do, how do you tell the difference between pyosalpinx and appendix? Well, in pyosalpinx, it's the outer border that's echogenic, and you have internal echoes within it with thickened septation, where the appendix will get gut signature with the inner layer of the mucosa that is echogenic, and then the outer layer that is hypoechoic. Another cause of pelvic pain is sometimes acute diverticulitis. So again, here you can see this is a tubular structure, which a patient was focally tender, but it's not. It doesn't look like a pyosalpinx because the echogenic area is actually in the middle, and there is thickened muscularis mucosa muscularis of the colon because of the inflammation, and you can see those nicely the corresponding CT of this patient with acute diverticulitis, again with fat stranding and echogenic fat on ultrasound. This is a patient with diverticular abscess, so she presented with pain. She was in her 50s, and here it's really hard to see what's going on. There is a fluid collection with internal echoes and some shadowing. And if you see air within a pelvic abscess, it's very, very uncommon to see that with regular run-of-the-mill pelvic inflammatory disease. If you see air in a pelvic abscess, think about the possibility of a GI origin. And here you can see on the CT, she had, again, a diverticular abscess, acute diverticulitis, which actually a diverticular abscess. And this is what we were seeing on the ultrasound. This is a patient with Crohn's disease who has bilateral tuburian abscesses. But in addition to that, she has this kind of fistulous tract. Again, echogenic fat, hypervascular lesion. And you can see the complex bilateral pelvic abscesses with fistulous tract in patients with Crohn's disease. And sometimes these patients will present first on ultrasound as their first manifestation of Crohn's disease. So you have to think about the diagnosis. Again, here's a thickened terminal ileum in that patient. Now, what about this case? So I'll finish by talking about some unusual cases. Now, usually uterine problems don't cause abdominal pain, right? Usually they cause vaginal bleeding. But this is a 24-year-old woman which had low abdominal pain. And so here's her uterus, looks fine. And then she has this other structure. And one of my colleagues actually called me and said, okay, I need a second opinion. What's going on here? She has this lesion here, and she has a lot of pain. So if you look at it carefully, it's very intimately attached to the uterus, right? And it kind of looks like an endometrioma. And so what's going on? So we figured it out. So what she had a duplicated uterus with obstruction of one of the horns. And that's why she had pain, because basically there was menses retention in this uterine horn that was obstructed. And the key here is that the blood looks just like endometriomas because it's recurrent bleeding, but there was a thick wall, which is a myometrium. It's very intimately attached to the other uterus. And so this is a bicornate uterus with an obstructed horn. Now, of course, what you see very common, you see sometimes in young girls, about 12 to 14, presented with abdominal pain. You have to always think about the possibility of hematocorpus here, very large distended vagina filled with blood. This particular patient also had a diadelphi uterus with an obstructed white horn by the vaginal septum, but most commonly they just have imperforated hymen. And then the other point I want to make here is that if you have a uterine duplication always think about what's, that this patient may have an absent ipsilateral kidney, as this patient had. She only had one kidney. Asherman syndrome sometimes will cause abdominal pain, again, because of the distension of the endometrium with a retained menses. This is a patient who had history of endometrial ablation, presented with abdominal pain several weeks later. Again, that's easy diagnosis, distended endometrium filled with blood. So in general, uterine pathology, as I say, are less common cause of pain, except if you have prolapse, submucosal fibroid. I showed an example in the prior lecture. Also misplaced IUD. That's something to think about. So I'll just show you a couple of cases. This is patient had pain and menorrhagia, both. And I think in these cases, having the 3D reconstruction is very helpful. You can see here this uterus is, the IUD should be up here, but here the T branches is, first of all, your IUD is tilted, and also the branch is extending into the myometrium, so there is myometrial penetration. This is what a normal placed IUD should look like. Very close to the T branch should be very close to the frontal portion of the endometrium. And then, so in malpositioned uterus, the arm may be extending outside the endometrium with penetration in the myometrium. It's called uterine embedment. Or it can be in the cervix. And oftentimes the patient will have abnormal bleeding and pain. And it's really important to also tell the patient, because the IUD is going to be less effective, so it may not work as well as a contraceptive agent. And then finally, I want to show this case just to help you or the sonographer, whoever is scanning, to look around. Right? This is a patient who had pain since placement of the IUD a week prior. And we didn't see the IUD in the endometrium at all, or in the cervix. But the sonographer was looking around, and here there is this what looks like a foreign body just outside, right? And basically this IUD had perforated outside the myometrium and was in the cul-de-sac. Excuse me. And finally, again, there are other causes of pelvic pain than GYN or even GI. And this is a patient who presented excuse me, with lower abdominal pain. And what the reason for her pain is that she had a dilated distal left ureter with stones obstructing it. And you can very nicely see the mild thickening of the ureter as well as the 2 stones in the distal ureter. So the take-home points is always evaluate the area of pain, because the indication may not always be appropriate. Correlate the ultrasound findings with the patient's symptoms. The presence of ovarian flow does not exclude ovarian torsion. And if there is no flow in a normal ovary, normal size ovary, normal appearing ovary, it's likely technical unless the patient is very symptomatic. And remember that because GI and GU pathology can also cause lower abdominal pain, always remember to look around at all the other organs adjacent to the GYN organs. Okay. Any questions, or should I just continue?
Ma'am, there are questions, and first of all, thank you once again. You have been taking so many important things together in one go. So really commendable, ma'am. And so there's a question, they want to know how to differentiate oophorytis and tossed ovary, as Doppler may be normal in initial phases of torsion.
Right. So first of all, sometimes just so oophorytis usually is a consequence of pelvic inflammatory disease. So the patient may have other symptoms such as foul-smelling vaginal discharge, cervical motion tenderness. And it's not always easy, but I think the position of the ovary, I think in ovarian torsion, I rely a lot on the position of the ovary. Oftentimes, the ovarian position will be abnormal, either in the cul-de-sac or above the uterus. So if the ovarian position is abnormal, I would worry about ovarian torsion. And in oophoitis, sometimes the flow will be increased, although it's not that common. Most of the time when I see oophoitis, usually there is associated thickening of the fallopian tube. Not always, but most of the time, at least in United States, because pelvic inflammatory disease here is like an ascending infection. So it will affect the fallopian tube before it spread to the ovary.
Okay, ma'am. Thank you for that. Another question is that if you could guide us regarding the PRF settings for seeing the ovarian and endometrial blood flow.
Okay, so what you need to do, so this is what I do. You try to optimize for slow flow. So oftentimes all the modern equipment have a slow flow button. That's the first thing to do. And then I try to make the scale as low as possible, the color scale. And the other thing I do is I crank the color gain up till I have artifact, and then I slowly crank it back down until the artifacts stop. And I think that's the best way to make sure that you have optimized for slow flow. Okay, so you have your scale down, okay, and then to, like 5 or maybe 7 centimeters per second, sometimes even less. And then I crank the color gain down up as much as I can until I have a lot of artifact, and then slowly dial it back down. That's what I do.
Great, ma'am. Thank you. That will definitely help us all. So I think now we can go ahead with the next talk of yours, ma'am.
All right. All right, so this last lecture is on ectopic pregnancy, meeting the terms, and what I'm going to try to do is, focus on the perhaps the less common aspect of ectopic pregnancy, the less common location. So I hope you find it interesting. So we all know that it has increased, the incidence of ectopic pregnancy has increased significantly over the past several years. Probably for 2 reasons. First of all, there is a dramatic improvement in detection of ectopic pregnancies thanks to endovaginal ultrasound and combination of endovaginal ultrasound and quantitative serum beta ECG. And also there are increased incidence of contributing risk factors such as pelvic inflammatory disease, treatment for infertility, smoking, etc. But the good news is that with endovaginal ultrasound, we have been able to achieve early diagnosis, which decrease not only mortality, but also morbidity, as well as allow less invasive treatment with better preservation of future fertility. So we'll go one by one through these challenges. So first of all, just in any woman of reproductive age, think about the possibility of an ectopic pregnancy, no matter what her presentation is. Because a classic triad of abdominal pain, vaginal bleeding, and palpable mass is not, palpable adnexal mass is actually not that common. So this is a good example. This is a patient who came in here. So she said, oh, the patient checked for IUP, the patient's pregnant, and she has wide upper quadrant pain, checked for acute cholecystitis. So her gallbladder was normal, but she had some ascites. And if you have ascites, fluid, I should say, it's not ascites actually, in a young woman, always think about the possibility for an ectopic pregnancy. So we looked in the pelvis, and of course she did not have an IUP, but she had an ectopic pregnancy with blood in the pelvis as well as blood in the moistened pouch, and that was what brought her to the emergency room, was her wide upper quadrant pain. So always think about the possibility of ectopic pregnancy in a young woman, and even if a pelvic ultrasound is not ordered, just look for it if you have that suspicion. Now, is transabdominal ultrasound still necessary? Again, we want to do things as quickly as possible. And oftentimes, this, at least in the US, they just order transvaginal ultrasound. I really think in patients with ectopic pregnancy, it is absolutely necessary to do a transabdominal ultrasound. First of all, it allows you to do a very quick survey of the abdomen. So in this patient who had here no IUP, large amount of clot, and probably the ectopic right here in the pelvis, we could quickly move the transducer up to the upper abdomen, see the extent of hemoperitoneum, and basically send her to the emergency room, to the OR, I'm sorry. This other thing is, I think that transabdominal ultrasound is really, really helpful in clarifying ectopic pregnancies in unusual locations. Now, the other thing that's important is to distinguish early IUP from its mimic, because now one of the treatment for early ectopic pregnancy is intramuscular methotrexate, okay? Or for medical abortion of failed IUP, so misoprostol. So we do not want to give methotrexate to somebody who could have an early IUP, right? So, and now we don't really, many of these early ectopics will go to treatment without laparoscopy. So it's really important, in my opinion, to make sure that you know that there is no viable IUP. And actually, that there have been lawsuits, at least in the US, for patients wrongly being given methotrexate when we weren't sure whether it wasn't made clear that there could be a viable IUP, if the report is vague. So it's really, really important. Okay, it's a responsibility of our responsibility to make sure that we don't terminate a potentially normal IUP. And because most women are hemodynamically stable, we really, if you're not sure, we have opportunity to do follow-up either with serial beta HCG or follow-up ultrasound. So when I have a question in ectopic pregnancy, the first thing I do is look at the uterus, because it's easy to diagnose an intrauterine pregnancy, right? So 90% of patients who are referred for rule-out ectopic actually have an IUP. And heterotopic pregnancy, or the presence of an IUP with an ectopic pregnancy, is actually uncommon. So if you have a pregnant patient and you've located the pregnancy in the uterus, you pretty much can breathe a lot easier, unless there are exceptional circumstances, such as patients who are treated for infertility. So let's look at the first challenge, is learn to recognize very, very early IUP and differentiate it from its mimic. So here, this is an example of very early intrauterine pregnancy. This is an intradecidual sac sign, very small gestational sac. But the reason I think it's a gestational sac, it's just underneath the endometrium, and it has this subtle echogenic border, right? So this, I would say that I said it is, if I reported this case, I would say it's very likely that it's a very early intrauterine pregnancy. However, of course, I don't see a yolk sac. I don't see a fetal pulse. So I cannot comment on the viability of the pregnancy, but I think it's more likely that this patient will have an early IUP and just follow the beta HCG. Where in this case, this is very different, right? There is fluid in the endometrium. The endometrium is slipped. This is inside the endometrium. So this is not a gestational sac. This is a pseudo-gestational sac in a patient that had an ectopic pregnancy. So just learn how to recognize the very, very early sign of a very small intrauterine gestational sac or early intrauterine pregnancy, so that this patient, you can be very clear that I think this could be an IUP, and don't give this patient methotrexate. Okay, so with ectopic pregnancy, what are the endometrial findings? Because the endometrium will undergo the decidual reaction from the hormone changes of the pregnancy, right? So you may have a normal endometrium, or you can have a thick endometrium, just as you see in this case. And this patient had a small ectopic pregnancy right there. Or you can have these decidual cysts, which are these eccentric cysts. Now, why is this a decidual cyst and not a gestational sac? They can be a little tricky, but this one doesn't have as well-defined echogenic border. I have to admit this is a little tough, right? But we always look very carefully at the adnexa, and this patient had an adnexal mass. And so she did have an ectopic pregnancy. In this old paper, Alliance from Winnipeg had thought that they had a 80% positive predictive value for early ectopic pregnancy if you saw this decidual cyst. I have to admit, it's very, very uncommon to see that. So I'm not sure I buy what they say, but I just want to put it out there because it was published. Okay, so if you have cystic structure in the uterus, it could be just fluid, or it could be early gestational sacs. This one, we don't see anything in there. This one, we see a little yolk sac. However, you have to be careful because what about this case? So this one kind of looks like a gestational sac, but it has internal echoes. And again, we always look very carefully at the adnexa. This patient happened to have also an ectopic pregnancy. And what we thought was that this was a pseudogestational sac. What happens is sometimes there is hemorrhage within the decidual reaction of the endometrium, and it can look like a pseudogestational sac. This patient was treated with methotrexate, failed, and underwent a saphenectomy. Okay. So the other thing is we need to, if we see an adnexal mass, we want to see is that in the ovary, because if it's in the ovary, it's much more likely to be a corpus luteum, or is it separate from the ovary in the fallopian tube, and that is much more likely to be an ectopic pregnancy. Okay, the vast majority of ectopic pregnancy are in the ampullary portion of the fallopian tube. So the ultrasound findings are pretty simple. No IUP and an adnexal mass separate from the uterus. And this has a very high specificity and sensitivity in this really old study, but this still holds true today. So the direct sign of ectopic pregnancy, adnexal mass separate from the ovary. So sometimes if you're not sure whether a mass is separate from the ovary or not, I mean, here it's pretty clear. This is a corpus luteum and this is the ectopic pregnancy. You can kind of push on the ovary, do a bimanual push on the ovary or the mass with a vaginal probe and push on the belly with the other hand, and you'll see that these two moves kind of separately. And so you know that this is a adnexal mass separate from the ovary. In this case, you could see a yolk sac and fetal pool as well. So that's pretty clear that this is an ectopic pregnancy. Now, it's very uncommon to actually see a live fetus. That's the least common presentation. A more common presentation is in a gestational sac. Again, why is it called an adnexal ring? Because it has a cystic area with an echogenic border. Now, this one has a yolk sac. So it's clearly a small ectopic pregnancy. And this was treated with methotrexate with very good response. Or sometimes you will just see an adnexal ring. In this case, the important thing here is that a patient was pregnant, has no IUP, and has a mass which is separate from the ovary. And she was treated with left saphenectomy. This is another example, again, very amorphous mass. So again, you have to make sure that you can separate this from the adjacent ovary because most ectopic pregnancies are in the fallopian tube. And sometimes all you'll see, and I saw a case recently, all you'll see is just basically hematosalpinx. You have a tubular structure filled with this amorphous material. But if you look very, very carefully, in the hematosalpinx, sometimes you'll see the ectopic pregnancy. And this is a pregnancy that was bleeding inside the fallopian tube. Now, she had a very high HCG. She was very symptomatic. So they did a saphenectomy and was able to take the ectopic out. She also had a hematosalpinx and then repair the fallopian tube. Now, again, just to show you how you differentiate a mass. Is this mass in the ovary or is it adjacent to the ovary? The ovary has a big corpus luteum. This patient also was pregnant, had complex fluid in the cul-de-sac. So every time you have echogenic fluid in the cul-de-sac in a patient who is pregnant, you have to be concerned that it's an ectopic pregnancy, right? And again, you press, you do a bimanual with the vaginal probe on one hand, the hand on the top of the woman's belly on the other hand, and you'll see that this moves separately from the ovary. Now what we're going to talk about is uncommon location of ectopic pregnancies. Okay, so the first one I want to talk about is interstitial ectopic pregnancy. That represent about, so they are in the interstitial portion of the fallopian tube as it joins with the endometrium at the cornea of the uterus. And the reason they represent about 2 to 4% of all ectopic pregnancy, but the reason they are dangerous is that they tend to have a delayed presentation with more advanced gestation. And because they are very large vessels in this area and they're supplied by uterine artery, there is a high risk of life-threatening hemorrhage when the pregnancy ruptures. These are the patients that may go, become hypovolemic and hypotensive very, very quickly. So they have a higher morbidity and mortality compared to the other ectopic pregnancies. So let's just show some examples. So this is actually an example of interstitial ectopic pregnancy that was missed on the point of care ultrasound in the ED. This is what they said. They said the patient had a abortion somewhere else. She had FHM on the ED ultrasound, but the patient wasn't doing well, so they wanted a formal ultrasound. The first thing you see again, why transabdominal ultrasound is so helpful, there's a large amount of clot in the cul-de-sac, and you do see this pregnancy, and there was a live fetus, but the pregnancy is very, very eccentric, right? And if we look on endovaginal ultrasound, you can see that there is myometrium on one side, but no myometrium on this side here. It's intimately related to the uterus. And there was a large amount of blood, and this patient became hypotensive very quickly. So very quickly shipped her to the OR, and she did indeed have an interstitial ectopic pregnancy that had ruptured. Here's her at the time of surgery. So what are the findings? Okay, you have an eccentric gestational sac, and you have the interstitial line sign, which is nicely shown on this clip where you see the endometrium, and then the corneal portion is extending towards this gestational sac here. There is no myometrium on the lateral aspect of the gestational sac, and you can see very, very large uterine vessels oftentimes. These are these patients. This is a different patient. You can see here's the ectopic pregnancy with these very, very large vessels. And you can imagine that if they rupture, the patient is going to become hypotensive very, very quickly. This is an advanced case. She was 14 weeks pregnant. And in this case, the pregnancy is eccentric, but sitting on top of the uterus, not lateral. So again, you have to be careful and recognize that this is actually not intrauterine. It is too high. And this patient was 14 weeks pregnant. She had increasing abdominal pain. The transabdominal is, I think, as good as the vaginal study to show how eccentric this ectopic pregnancy is with no myometrium on this side here. And again, she needed to have resection of a 10 centimeter corneal mass. So she needed an open laparotomy. So something about terminology, a little bit confusing, but now the OB literature recommend that we call these pregnancies interstitial and not corneal. Corneal pregnancy is reserved for pregnancy that occur in the cornea of a bicornuate or septate uterus. And then there is another entity called angular pregnancy, I shouldn't say ectopic, angular pregnancy, which implants in the lateral angle of the uterus. Okay, so you have the interstitial ectopic that's in the interstitial portion of the fallopian tube. You have angular pregnancy that are too lateral, but still within the uterus. And then you have the corneal pregnancy that are in the cornea of a duplicated uterus. And so sometimes it's difficult to differentiate those, or 3D is maybe helpful because you can then obtain a true coronal plane. So again, the differential diagnosis here is a pregnancy this is a true corneal pregnancy. It's eccentric because it's one horn of a bicornuate uterus. And again, in this case, you see myometrium around the gestational sac, unlike the cases I just showed you. But if the diagnosis is unclear, you can get a careful follow-up or you can get a pelvic MR. Okay. Now, angular pregnancy is uncommon. Okay. This is implantation into the lateral angle of the uterus medial to the tubouterine junction. It's technically intrauterine, but it's fraught with complications with a high risk of uterine rupture, placenta accreta, and spontaneous abortion. And what you're going to see is a gestational sac that is too lateral, but still surrounded by myometrium. And you can look for associated complications such as myometrial hematoma. And this patient was actually, she didn't want a pregnancy anyway, so she was treated with methotrexate. But we thought this was an angular pregnancy. And again, I think the 3D can help. This is a case I just showed you of the angular pregnancy. So you can see on the 3D that it's still within the uterus, but it's just at the edge. Instead of being more central here, it's really at the edge, but there's some myometrium surrounding the sac. Whereas this is a true interstitial ectopic pregnancy, which is more eccentric, and there is no myometrium on the lateral aspect here of this ectopic interstitial pregnancy. Okay. Another less common type of ectopic pregnancy is cervical ectopic pregnancy, which are uncommon. So there's implantation in the cervix, which should remain closed. And it's really one of the main differential is whether it's a spontaneous abortion, which is much more common, or cervical ectopic pregnancy. But again, these also have a massive risk of bleeding if they're not treated accurately. And their management usually methotrexate or KCL. So here, so look at some example. What you're going to see is a gestational sac within the cervix. Now, if you have a live embryo like this case, with a yolk sac, it's relatively easy to make the diagnosis. But you can see the hourglass deformity of the cervix. And if you're not sure whether it's a cervical ectopic or an abortion in progress, you can just get a follow-up. And usually with abortion, you have some change within 24 to 48 hours, whether, of course, with a cervical ectopic, the pregnancy will not move. So this is an easy example because there was a live fetus in this cervical ectopic pregnancy. This was very difficult to treat, and what they did was they did a DNC, very careful DNC, because there's a major risk of bleeding, and then they put a Foley in the cervix to try to tampen it, and actually this was successful. Now, what about this case? So in this case, you see this gestational sac, and there is something in it. This didn't have heart motion, and we really weren't sure whether it was a cervical ectopic with embryonic demise versus an abortion. So what we did is get a follow-up ultrasound, and 24 hours later, this was gone. But if you're not sure, you can do an MR, and you can see here these ectopic implantation in the cervix with the cervical close in the sagittal MR. And this was treated with methotrexate. Now, abdominal pregnancies are very, very uncommon. I've seen only one or two examples. What happens is that there is rupture of likely a ruptured tubal ectopic pregnancy that then implants into the abdomen. What you're going to see in an empty uterus with a fetus that's separate. Oftentimes there's oligohydramnios. We have seen some cases that are more advanced, and then MR is really great to make that diagnosis. Now, another ectopic implantation that is becoming more and more common, at least in the US because of more and more C-section, is a cesarean scar implantation. Technically, again, they are intrauterine, but it's still an abnormal implantation. And so what happens is that this implants into the defect right there in the lower uterine segment of previous cesarean section. And above, something to think about, because some of these patients are completely asymptomatic and you may be the first one, making that diagnosis. So what you're going to see, as you can see here, is that there is a sac that is basically implanted into the C-section scar. So it's a little bit, it's too low an implantation, but unlike cervical ectopic, it's a little bit more superior and oriented anteriorly towards the bladder, where the C-section scar normally is. And what you're going to see is that there is, if the pregnancy grows, there is basically no myometrium between the pregnancy and the bladder. And again, sometimes it's easier to see, I think, on the transabdominal, where you can see here, this is a patient with a history of lower, she had a history of a prior myomectomy and C-section. She came for routine dating. She was totally asymptomatic. And you can see here the abnormal implantation of the gestational sac with no myometrium between the trophoblastia and the bladder. And at laparotomy, you could see this ectopic pregnancy protruding into the surgical defect. Again, another example, same thing. And if you're not sure or the GYN wants to plan for treatment, you can see on the MR again, implantation in the C-section scar with no myometrium, a very thin myometrium between the bladder and the gestational sac. Now, ovarian ectopic pregnancy is incredibly rare. This is the only case I've ever seen. So I always say if you see a mass in the ovary, it's not going to be an ectopic pregnancy. It's going to be a corpus luteum. This is the only exception I've seen of this lesion that was intimately related to the ovary. There is a yolk sac here, but that's really the only example I've ever seen. So I think they're incredibly uncommon. Something that's not as uncommon is heterotopic pregnancy, where you have an intrauterine pregnancy with an ectopic pregnancy. It's more common in patients treated for infertility. And the challenge, again, is that, remember I said if you have an intrauterine pregnancy and a patient is pregnant, you can breathe easy, except in these cases. So what you're going to see is not only you're going to see an intrauterine pregnancy, but you're also going to see an adnexal mass separate from the ovary. And of course, always look for blood in the pelvis or hemoperitoneum. And we really have to have a high index of suspicion in this patient. Any patient who is pregnant, even if you see an IUP, but there is blood in the pelvis, or the patient's an unusual amount of pain, you should think very carefully and look very carefully in the adnexa. And of course, it's a management challenge as well, because you want to try, and most of these patients are fertility patients, and so you want to try to save the viable intrauterine pregnancy. So a couple of examples, patient who had IVF abdominal pain, so she has an IUP, but she has complex fluid in Moissan's pouch, she has the liver, and so she has hemoperitoneum. And so we look around very carefully, and here's her ectopic pregnancy. So she had an IUP with an ectopic pregnancy. And fortunately, they were able to take out this ectopic pregnancy, and her IUP remained viable. And finally, can we diagnose rupture of ectopic pregnancy? And so basically, the bottom line is that you really cannot. If you see a lot of free fluid or free blood, that's a better predictor. But basically what I always say, if I see a lot of fluid in the pelvis or even moisture spot, it could be ruptured, means the tube is actually busted, or just leaking. The pregnancy itself is bleeding and the blood is coming out the fimbriated end of the fallopian tube. And basically probably doesn't matter, because if there's a large amount of blood in the abdomen, this patient will need to go to the OR. Okay, so this was a large 7 centimeter, 8 centimeter hematosalpinx with large amount of blood in the pelvis. And this was a ruptured ectopic pregnancy. And the other thing, the important, we should have mentioned that the mass was too large to be removed easily from laparoscopy. This patient is a unfortunate 11-year-old girl who was pregnant with large amount of blood, tons of blood, as you can see. Here's her ectopic pregnancy, and although it, for all the world, looked like it's a ruptured ectopic pregnancy, in her case, it was just unruptured, but bleeding from the fimbriated end, and she had gross amount of hemoperitoneum. So in the end, when you do the ultrasound report, it really should be geared to guide management because there are 4 potential management strategies. Sometimes, so you're going to look at the size of the adnexal mass, the presence of cardiac activity, the presence and amount of abdominal and pelvic blood, and if you need a follow-up, you should recommend it because basically there are several things that can happen. Occasionally, we've seen spontaneous resolution of ectopic pregnancy. And so this patient have a very small mass with low HCG, of course, no embryonic heart motion, and perhaps less vascularity on color Doppler, so that's kind of questionable. And this patient sometimes maybe just followed if the pregnancy is very small and left to be resolved on its own. Or, of course, you can take with methotrexate, which is now, fortunately, one of the very common thing we can offer to this patient. Avoid surgery on their fallopian tube, provided that the adnexal mass is smaller than 4 centimeters and there is no embryonic cardiac activity. It's also the management of choice for this unusual location of ectopic pregnancy, such as cervical ectopic pregnancy or interstitial ectopic pregnancy, if they're diagnosed early enough. And then, of course, either laparoscopy or laparotomy is reserved for patients who are hemodynamically unstable or have very large ectopic pregnancy or have embryonic cardiac activity or have failed methotrexate therapy. And finally, interventional, occasionally, again, in this unusual ectopic pregnancy, you can either offer methotrexate or sometimes KCL injection to basically do, kill the embryo, or you can also offer uterine artery embolization. And so I want to really thank you for your attention. I want to thank Sonobuzz and the organizer for inviting me. And I want to wish everybody a happy, healthy 2021 where maybe we can go away from this virtual meeting and meet at least our family and friends and colleagues in person. I thank you very much for your attention.
Thank you, ma'am. And thanks a lot for your time and efforts and contribution. It was really nice listening to these important topics, but because this is something which we do come across in our day-to-day practice and we do get confused at the important perspectives. So thank you, ma'am. Thanks once again. But I would request you to please stay online because there are questions in the chat box. So we'll just try and take few.
Sure.
So, yeah, ma'am. So one is like they want to know the tips to diagnose ovarian ectopics. You have already discussed, but it's difficult. It's difficult. They are saying multiple times. So few important tips.
I mean, honestly, I have seen only one case of ovarian ectopic pregnancy. And, it's, in this case, we were lucky because there was a yolk sac. I think ovarian ectopic pregnancy is very, very uncommon. If people have seen more, I would love to share their cases because usually, I mean, okay, if you see, let's put it that way. If you see an ovarian lesion, most of the, in a pregnant woman, the vast majority of the time, it is going to be a corpus luteum, okay? So if you see a classic finding of a corpus luteum, either a cyst with thin wall and no echogenic rim, or a collapsing corpus luteum, they have a pretty characteristic appearance. There may be a thicker echogenic rim, but it's kind of have a granulated appearance. It doesn't look like a nice, very echogenic rim of the trophoblast. That's the only thing I would say. But again, I've seen like thousands of ectopic pregnancy. I've seen only one case of ovarian ectopic. Unfortunately, there was a yolk sac at least in it. But it's really can be very difficult. But as I said, it's really, really uncommon. That's our only saving grace.
So if you are saying it's uncommon and you have seen it only once, then definitely it's very
really
difficult to find
right.
one.
I mean, that's really, really uncommon. And I've asked my colleague, maybe I have one colleague that have one more case, but it's really rare. Fortunately, I think these other ectopic pregnancies, particularly interstitial and cesarean section scar ectopic, can be tricky if they are advanced, because I've seen those being mistaken for intrauterine pregnancies.
Okay, ma'am. Another question is how to differentiate a large endometrioma from a mucinous cyst adenoma.
Okay, so mucinous cyst adenoma, usually they have this multiple, the typical appearance of a mucinous cyst adenoma is these multiple septations. They're very very, very large mass and they have a lot of septations. Endometriomas usually have these ground glass low-level echoes. But again, if the mass is very large, more than 7 centimeters, I always recommend, and I think this is kind of standard here, that they get an MR, because above 7 centimeters, it's really hard for ultrasound to really fully characterize the lesion. And certainly over 10 centimeters, another study definitely should be done. But typically, mucinous cyst adenoma will have multiple septations, whereas endometrium will have the diffuse ground glass low-level echoes. The other thing is if you see these little echogenic foci, sometimes with cometal artifact near the wall, that's an helpful sign that this may be an endometrioma because these are like debris from hemosiderin reabsorption.
Okay, ma'am. The next question is about size criteria. How to characterize whether a uterus is bulky or not? Are there any cutoffs for these?
I don't like numbers. So, I mean, and it's so variable, right? It depends on the age of the patient. It depends whether it's a nulliparous or not. So if the patient has had 3 children versus no children, it's going to be different. So I think if it's above 12 centimeters, I think I consider that bulky. And also if it's more globular in shape, so it's not just one dimension, it just looks more, globular, I would say. But that's just one criteria. I think that in a patient who is multiparous, she's going to have a bigger uterus. So I think this is really it really depends on the patient. I think I would say above 12 centimeters, uterus is enlarged. But these are really like rough criteria. I think more importantly, look at the appearance of the myometrium.
Okay, ma'am. So I think that will definitely help us, and we should also not run behind numbers and cutoffs. So the next is, ma'am, how to differentiate between interstitial versus cornual pregnancy. So what is the difference and how to differentiate?
Okay, so there is a lot of confusion in terminology. We used to call this, so interstitial pregnancy is in the interstitial, I don't know can you still see my screen?
Yeah.
Okay, so let me go, okay. So interstitial ectopic pregnancy are they are in the fallopian tube, but they're in the portion of the fallopian tube that enters the uterus. Okay. We used to call them cornual, and that's a term that the obstetricians say do not use. You use the term cornual pregnancy nowadays if it's in the cornua of a duplicated uterus. So if it's a cornua of a septum, or you have a didelphys or bicornuate uterus. But if it's in a uterus that's not duplicated, and it's in this portion of the fallopian tube, you have to use the term interstitial. You don't use, the only time you use cornua, at least according to the obstetricians, and that's what we do now, is if it's in a bicornuate or didelphys uterus.
Okay, ma'am. So I think most of the important questions.
So in other words, if you have a cornual pregnancy, there will be myometrium surrounding the entire pregnancy, versus if you have an interstitial ectopic pregnancy, then you will have, as this case, you will have no myometrium on the outside because the pregnancy is only partially in the uterus.
Great.
In the fallopian portion of the portion of the fallopian tube that's entering the uterus.
So I think that is a very important pointer, how to differentiate between the two. So thank you for sharing that, ma'am. I think most of the important questions we have taken, we can just take one more, and so that is what to do like bilateral multilocular cystic lesions without hyperstimulation. So what should be done for those?
And obviously without molar pregnancy, I assume.
Yes, ma'am.
Well, then I mean, you have to at least consider the possibility there are bilateral ovarian tumors. I mean, occasionally I've seen. I mean, they will not just look multilocular. I mean, but I've seen, ovarian cancer metastasis to the other ovary, or like the case I showed you, worry about the possibility of, mets from other areas, such as, for example, mucinous colon cancer. So I think if you see that, but they will look a little bit different. They won't look exactly like hyperstimulation, but they could have bilateral and large ovaries. And I would definitely recommend another study, like get an MR if you can.
Okay, ma'am.
Because the only two things that we're going to give you hyperstimulation are is either gestational trophoblastic disease or like fertility treatment. Now, I mean, the other thing is I've seen one case, it's very uncommon. I've once seen a choriocarcinoma with hyperstimulation. So always look at the uterus very carefully to make sure that there's no mass or something funny in the endometrium of the uterus.
Okay, ma'am. Ma'am, any specific role of PET CT, like indications in ovarian lesions, when to go for PET?
For staging, I mean, we do it for staging of ovarian cancer. On the flip side, I think I've seen ovarian lesion, especially in young women that are PET positive. Let's say you do a PET in a young woman for other reason than ovarian cancer. Like follicles can be PET positive because they have neovascularity, right? That's normal. So not every PET positive ovarian lesion in a young woman is going to be an ovarian cancer. That's very important to stress as well. So if you see a PET positive ovary in a woman, probably get an ultrasound because you'll be able to characterize it better.
Great, ma'am. So the questions will still continue to come up, but I think the important ones we have already discussed. So thank you, ma'am. Thanks once again for taking out time and being with us for these 4 important topics. We're looking forward into the future for more such associations. And as you said, maybe we'll meet soon physically rather than all these online interactions.
Okay, thank you very much, everybody, and have a happy and safe New Year, and hopefully with a lot of vaccine in the making. Take care, everybody. Good night. Oh, good day. I should say it's good night for me, but good day. Bye-bye.
Yeah. Bye, ma'am.